Hi, our group is going to talk about the early detection and monitoring of cardiovascular diseases in women, and the group consists of me, Juliana, Mizue, Pete, and Zara. Cardiovascular diseases, or CVD, refers to conditions affecting the heart and blood vessels. It is well known that the underlying cause of heart disease is the plaques of atheroma that form on the walls of blood vessels. In spite of a common cause, there are several types of heart disease, but the most common ones are coronary heart disease, stroke, peripheral arterial disease, and aortic disease. As you can be seen here in the graph by our world in data, CVD is the main cause of death around the world still nowadays. In the UK, even though over the years there has been a decrease in the number of deaths by heart disease, it is still one of the main causes of both death and disability. When CVD doesn't result in death, it can cause severe disability, so the treatment will be specific and depend on the extent of the condition. However, the focus is mainly on prevention, and according to NICE, the risk factors can be grouped in different categories. Non-modifiable risk factors such as age, gender, family history, and ethnic background, comorbidities such as hypertension, diabetes, and chronic kidney disease, amongst others. But most importantly, there are several modifiable risk factors that can be closely monitored in order to prevent this disease, and some of these are smoking, high cholesterol, lack of physical activity, unhealthy diet, high alcohol intake, and overweight and obesity. As of now, the NHS has several prevention strategies in place. Primarily, the NHS Health Check program is designed for people aged between 40 and 79 years old who haven't been diagnosed with CVD, diabetes, or chronic disease. Includes an assessment of alcohol consumption, cholesterol level, BMI, dementia, screening for diabetes, and kidney disease. It aims to provide support and advice to help reduce identified risk factors. The secondary prevention strategies are aimed at people who have already been diagnosed with CVD, offering risk factor modification and cardiac rehabilitation. And at population level, these strategies are focused on people who are at low or moderate risks of developing CVD, seeking to influence diet, alcohol consumption, smoking, exercise, etc. So, a critical role for the NHS is the early detection and improved management of high-risk vascular conditions. To help with this, in 2016, the NHS Right Care developed an improved pathway on CVD prevention. It is evidence-based and developed in collaboration with several national institutions such as Public Health England, Royal Colleges, and NICE. The aim is to provide best practice pathways for individual conditions and to show what to change, how to change, and the scale of improvement. So the CVD prevention pathway is built around these 6 high-risk conditions: hypertension or high blood pressure, atrial fibrillation, high CVD risk and familial history, pre-diabetes, type 1 and 2 diabetes, and chronic kidney disease. These conditions are often diagnosed late and suboptimal treatment is common. For each condition, the pathway shows opportunities for what could be improved and the evidence supporting it. For instance, in the case of high blood pressure, 5 million people go undiagnosed and around 40% have it poorly controlled. The evidence suggests that BP lowering prevents strokes and heart attacks. It also gives you a clickable link to a document with information about prevention, detection, and interventions that can support improvement. So apart from the results from the test from the NHS Health Check, there are system-level guidelines to help clinicians choose the best course of action for treatment of each of these conditions. Ultimately, these are the expected outcomes for the measures that were put in place. For high blood pressure, for instance, the expectation is to reduce 50% of all strokes and heart attacks, plus chronic kidney disease and dementia.
CVD deaths account for around a third of all deaths in the UK. A quarter of CVD deaths occur in people under 75 years of age, and 70% of deaths occur in men. Mortality from CVD is declining, while morbidity is increasing. CVD risk includes modifiable factors. Therefore, improving care pathway, identifying those at risk to introduce early interventions is crucial. Prevention of CVD involves a wide range of stakeholders. For example, NICE lists 300 UK organizations as stakeholders. Prevention also includes patients who are often unaware of their risk. Therefore, both primary and secondary prevention must be considered with broader touchpoints to identify at-risk populations and take collaborative actions. According to the British National Register, women are 50% more likely than men to receive an incorrect initial diagnosis following a heart attack. 3 middle-aged, slim-figured women who were unaware of their risks highlight this situation. Fran has type 1 diabetes and visually impaired at age 34. When she had a heart attack, she'd been cold and shivering but didn't have any pain. Carol has a high-risk family history and experienced gestational hypertension. When she had a heart attack, she was misdiagnosed with panic syndrome and suffered heart failure. Anne underwent heart surgery at age 19. She saw a cardiologist because of dizzy, but the doctor was dismissive of the severity, leading to the heart attack. There are human and systemic problems in this situation. Patients are often ignorant of risk and the disease or have atypical symptoms. Healthcare professionals may be biased in atypical cases. This situation may be due to systemic problems such as inaccessibility to the patient's full medical records and lack of learning opportunity, as well as inadequate screening and risk tools. These issues will be discussed further.
Currently, the NHS are focusing on the detection and treatment of atrial fibrillation, high blood pressure and high cholesterol in both men and women. Although these are big risk factors, as yet there does not seem to be a push to remedy the imbalance we've discussed in the correct initial diagnosis of CVD in women, with NICE saying that it plans to work with the British Health Foundation to explore their work on health inequalities in the future. As we saw in the earlier slide, misdiagnosis of CVD in women is a result of both human and systematic factors. Clearly, the lesser known additional symptoms that are predominant in women need to be understood by the public and clinicians alike. A public health campaign is needed to publicise these facts. We have also identified several opportunities that could be used to screen women for CVD at maternity and postmenopausal stages of life to target emerging non-traditional risk factors that can be overlooked. There are risk factors for CVD specific to women due to pregnancy complications such as preeclampsia and gestational diabetes. According to a paper by Keptipi Arachi, women who have had these conditions more than double their risk of developing CVD later in life. Our suggested improvement would be to identify women who had had pregnancy complications either through the NHS maternity dataset or through the maternity system or through the community health visitor who attends the mother after birth. The required measures for the risk stratification tool, such as blood pressure, cholesterol, and other lifestyle questions, could be recorded. Those women identified by the tool as medium or high risk would be invited for further tests at a cardiology clinic. Other groups of women that are often missed in their initial diagnosis are those at postmenopause or who have had a hysterectomy, where reduced estrogen levels mean that they are less protected from CVD. We want to lessen the risk for these groups by using the existing scheduled touchpoints into the healthcare system that already exist. Cervical and breast cancer checks are offered every 3 to 5 years. And there is also the existing 40+ check that's scheduled every 5 years. There are also opportunities to target patients through NHS datasets such as the Outpatient Commissioning Dataset and GP datasets. Through extracting data on patients who are overweight or have diabetes or over 55, there is an opportunity for healthcare providers to use existing data to write to patients and offer a CVD health check. The same CVD risk stratification tool would determine if the patient is at risk, and further preventative advice or treatment could be offered by a cardiologist.
Hi, this is Zahra, and I'm going to present the usage of AI and digital apps to monitor and predict cardiovascular disease or CVD in women. So, according to this study, the researcher classified women in three categories: young, pregnant, and old or in a menopause stage. In each of these categories, there are certain medical exams and risk factor assessment to screen for CVD. Furthermore, the researchers recommend following extra steps, which are by using AI and digital tools to enhance the screening of CVD, as well as to improve the patient outcomes. As you can see here, there are different types of AI methods or smart apps to predict certain heart diseases. And also there are interactive tools and apps to assist and educate patients. The researchers in the aforementioned study and these studies focused on smart apps to recommend specific learning material based on the patient's health conditions. Smart apps to recommend a healthy diet based on the patient's health status as well. Also, apps to prevent CVD based on current risk factors. Also, the literature suggests using digital monitoring apps that could be used at home to watch the patients who are at risk, where the health info is sent to electronic medical record of a hospital or medical center, and then the patients could be contacted for necessary medical interventions. There are several studies that show using AI method or deep learning techniques could improve the screening for CVD as well as provide a cost-effective means. In these studies, for example, they trained a deep neural network model by using a heart disease dataset collected by a 12-lead ECG device, and then they use the pre-trained model with a 2-lead mobile ECG device to predict heart disease. This method could provide an effective CVD screening where a standard 12-lead ECG is not accessible or cost-effective. Also, in this research, they trained neural network models, and then they used a low-cost BCG system to record heart sound and used the pre-trained neural network model to predict the heart disease.